Hi, welcome to Doctors on Doctors by Bangalore Hospitals. I'm your host, Dr. Lahari Surapaneni, and I'm here to bring you all the behind the scenes for doctors, especially the ones working with us in Bangalore hospitals. Today, I want to welcome a very, very special guest, Dr. Divya Renu, who is our premier radiologist in Bangalore hospitals, and we are so happy to have you. Welcome, Dr. Divya.
Thank you, Dr. Larry. I'm really excited to be here.
Yes, I am too, because so far we've had just guys on the podcast and we're finally getting to the girls. So we are here to talk about our lives and our work and what we do every day. So me and Dr. Divya see each other all the time. And for the podcast, I'm just going to go ahead with Divya.
Yes, for sure.
So let's get to our first question. And, what do you mean by the radiation? So some people think that the getting a CT scan is a little dangerous and you should only get the CT if things are bad and you really need imaging. So how bad is the radiation exactly?
Yes, that's a very good point because there are a lot of myths around the scanner. Definitely, so what is a CT scanner? It is basically an advanced form of X-ray, right, with advanced software. So there is a radiation for sure, but with recent advances, the radiation dose has constantly come down. We should only as like in medicine, like we give any tablets, even paracetamol, we see risk versus benefit always. So like this, same thing applies to the CT. We have to look at the risk versus benefit, and when the risk outweighs, we should definitely go ahead with the CT scanner. The radiation from a body CT is somewhere between 3 millisievert. It's the unit that we measure it in. It's somewhere between 2 to 10. Like for a head, it is 2 millisieverts. And to give you the context, the background radiation that we receive is 3 millisievert.
Okay, what's background radiation?
Like in the environment that we live in, we anyways get natural radiation. And so depending on the, like some people who are living at heights, at mountains, they get even higher radiation. In fact, we take a flight from here, India to US or anywhere, we get radiation even in the flight as well. So there's no shying away from it. But in the right quantity, it is useful then harmful, and so only if you're say getting 10 scans a day 10 scans in a year, I mean, then only
you're gonna get into trouble.
So nobody is going to write you 10 scans in a year. So it has to be used judiciously, that is, I will say.
So the millisievert background radiation is about 3, you said?
Yes, 3 millisieverts. Like chest X-ray is 0.5, right? But in 10 days, I'll anyways get that much radiation from the environment. So I get kind of a chest radiograph done every 10 days.
Okay.
So to put it into perspective in a common language.
To understand relatively how.
So we have to use it judiciously. But some of the investigations like ultrasound and MRI, they have no radiation.
So we, the 640 slice, we use even as whole body scans, even for people who just want checkups, because our whole body scan, the radiation is pretty low too. So that's also 1 to 3 millisieverts in this machine.
Yes. So that's also, it's like, because I have been reporting whole body CTs and patients are often surprised how many things are hidden in our body. It's like opening up a Pandora's box. So, but then we know what to be cautious about. It's not like they're going to get it repeated CT scanners. They can follow it up with ultrasound and MRIs, whole body MRIs we have been doing as a preventive measures. So now medicine has moved from just diagnostic to preventive. So we are doing that at our hospital.
And prevention really is better than cure because it's just easier. And it takes less time, less effort, less money if you just are proactive about your health.
Talking about the prevention. So right now we have a health check package in which people are coming for calcium scoring. And so many times, so basically what is calcium scoring? It is to identify what is the calcium load on your heart, and we can put a risk based on your age, what is the risk that you have, and then and you'll be surprised how many people actually get a scan done, and then they are followed up with the cardiologist, and because they are at the risk. So sometimes we don't even know what's going on in our body, so it's good to know, as you said.
So I usually advise pretty much around 40 to kind of get your heart checked, get the calcium score, get the angiogram, echo, ECG. That we call that heart at Bangalore hospitals. We call it Heart 360 because the echo shows the contractility and the morphology of the heart and its chambers. So what does the heart look like, and are the chambers contracting? Is the blood flowing through properly in the right pressures? And then ECG shows the electric abnormalities. Treadmill test shows your heart under pressure because you're walking or running, and then it's connected to an ECG and it shows, if there's any electrical abnormalities. So it's important to do all of these. You can't also just get a calcium score and just call it a day. You need to really make sure every aspect of your heart is being looked at. And then we also started doing a lot of people who have seen the CT machine. They're like, well, can I just do my whole body? And so we've been doing a lot of those. And I recommend like whole body ones and then follow up whatever needs following up. And if you want to continue the whole body process, do an MRI full body once a year. And then you can alternate it after a few years with the CT whole body, especially because we have the luxury of doing that in Bangalore hospitals because it's a really, really incredible machine. So that's a disclaimer. So this kind of concept doesn't work in every other CT. So could you shed some light on why it doesn't work on other CTs and only the 640 you can kind of do these whole bodies?
As the number of detectors increase, the time of the duration of the scan reduces because it is that many number of slices we could do at a we can do larger slices at a time. So 640 means it's a very fast scan, and the time the patient is under the rotation or under the X-ray machine is less, so the radiation dose is less.
Okay. So let's break it down for people who are watching who need absolute clarity on what a CT machine is. So let's go to Dr. Divya, and I'm going to ask you very simple questions that probably both of us know, but others may not be aware. So what is a slice in a CT machine?
Slice is basically what is the thickness that we can feed through. So the smaller the slices, the more accurate and precise the images. And because of the smaller slice thickness, we are able to get that isotropic data that I was talking, and we can reconstruct it in any way we want because we have that precise information from each and every part of that body.
So you mean slice of the body?
Yes.
Okay.
When we plan a CT scan, so we keep the slice very small, and then we get it accurate. And because this is a 640 slice, so we get it very fast. We are keeping the slice thickness minimum, and we get a very fast scan.
Okay.
So the duration is proportional to the amount of radiation that the patient is going to get. So when it is fast, the patient is not there in the gantry time. The number of gantry rotations are less because the number of detectors to detect that X-ray is more.
Yeah, and the faster.
So that's why we are able to do in 3 seconds, 9 seconds because there's so many detectors to detect that data.
So why do they call it 640 slice and 320 slice?
It's the number of detectors. The number they are in a circle.
Yeah.
So the number of detectors are more.
Okay.
So we can't say because even in the fourth generation we can always take 1 mm.
So I want to talk about the fact that we're doing a lot of coronary angiograms on the CT, and actually the machine is primarily being used in our American hospital for cardiac imaging. So if you could name 3 points that make this the superior machine for cardiac imaging, why would you say that?
One, as I mentioned earlier, when the number of scanners are less, the scan time is more. We need to bring heart as a beating structure. So we have to get that image within that beating structure. So we have to bring down within the beat.
Okay.
So we have to bring down the heart rate. So we prepare the patient on the tablet. We have to give a tablet in the morning, and then
other machines.
Yes. So bring down the heart rate to 60. up to 70 maybe, to ideally and up to 60, to get a good image without an artifact. And if the patient, when they go into the scanner, they get nervous and the heart rate goes up, so we are not able to sometimes get the image which is clear enough. And because the scan is very fast, we can capture in a heartbeat, literally. So we, even with higher heart rates, we are able to do. We are not even preparing with the tablet. If the heart rate is up to 80, like the 80 and up to 90, also we have got some very good scans which are very readable without any artifacts. And even in the fibrillation patients who have ectopic hearts, so in all that also we are able to get very clear images. So that is the biggest advantage. So like for cardiac, minimum requirement when I was doing my post-graduation used to be 64, and that was, that is, you can't do cardiac scanning in below this mark.
In below
64.
Below or above?
Below, you can't even do it because it's a beating structure. So we need the scanner to be fast. And with 640 slice, it is so fast that we need not even, most of the patient, we don't even have to bring down the heart rate. We are still getting the image. So that's a very big advantage.
So I'm a plastic surgeon, so I had no idea about how great the machine was when it came. In fact, I was like, I would have, like this, what's so great about this machine? But then I had been scanned a few times and that was super easy. And then when I'm watching all this, I'm like, oh, this is a pretty good machine.
Yes, that's right.
So in Singapore, how was it? How was the daily work life?
It was very, very busy.
Yeah.
It was a very big hospital where the 3 MRI and 4 CT scanners.
Oh, really? 3 MRI. And what were the slices on those CTs?
So it was very, very hectic, very... the thing about Singapore healthcare is that it is very, very systematic and everything. I know what happened to the patient 10 years, 15 years back. So that is very helpful.
Because of the way they collect history?
Yes. So Indian system is completely different. And it is the best thing about Indian healthcare is it's accessible. It is so accessible to see a specialist. You just have to go to a specialist. Whereas, in other developed countries, it can take like months to reach.
In America, you have to see the GP or family, and then they have to, prescribe for a consultation with the super specialist, and then
Yes,
so that you kind of lose a bit of time there.
Yes. Time is the key. Time is the key. Yes, that's right. Absolutely.
Okay.
Time is the king, and
definitely. Yeah.
And we don't realize that how accessible and good healthcare we have in India.
In India, abroad, people are like, they almost, when I say I live in India, they almost see it as like, you live in a backward country or third world country or whatever. I'm like, you don't understand, because I don't wait for healthcare, period. Any hospital will take you, because also from a business standpoint, the hospital business is so competitive because there's so many hospitals. And in America, there's a radius where you cannot set up 2 hospitals in one area, just because they want to make sure the entire country has access to healthcare. Whereas on my road, there's like 6 hospitals. So it's crazy. And it's also such a blessing to be able to have that. And you need only choose the people who have the right technology, the right doctors, and that's what's most important. So that's something I always say, is that luxury in healthcare isn't the wallpaper or the color of the bed sheets, or how many, if you've got a living room in the front or whatever. Although comfort is important, but basically you need to make sure you've got the best equipment, right? My husband Abhishek was not feeling well like a few years ago, and this is when we were in training before the hospitals are set up. So we had taken him for a scan, and that was like in a 3 slice. And even to this day, I think normal people, we don't really think about it. Until I got this CT, I never thought about, this slice means I can have this much radiation, or they may not have imaged every part of my body. Maybe they missed something. These are all doubts that even sometimes I think, like, putting him in that scan machine, maybe, I have these doubts, like, maybe something's missed or something. So That way, it's really important to do your research when picking a hospital.
Yes.
And nowadays, like without medical technology, the show's not going to run. So you need to have that and upgrade yourself.
Yes,
And
absolutely.
so you're liking coming back to India?
Yes, definitely. That's where my roots are.
Yeah. So you're
Yes.
born here?
Yes, yes.
Yeah. Okay.
Yeah.
And husband?
Yeah, both of us are born and raised in India.
In Bangalore?
No, in UP, Uttar Pradesh.
Okay,
Yeah.
okay.
Then I, after marriage, worked in Bangalore. Then moved to Singapore.
Yeah.
Then I also worked for UK for a year.
Okay.
And then I joined Bangalore hospitals.
Yeah. And how do you feel the healthcare system is in India? I'd say for a doctor, how would you say working in a hospital in India is different from working in a hospital in Singapore? Top 3, because I'm sure there's a huge list.
I have to think of positives.
Think of positives. Yeah. Please
got
try. You're working in my hospital, so kindly.
I just missed.
Yeah.
Let me think.
Yeah.
Let me think. Yeah.
You can put a little clock
Yeah.
while she repeats.
So working in, especially I can talk about after coming back, I've joined Bangalore Hospital. And the best part about Bangalore Hospital, we have our CEO is a mother herself, surgeon and a CEO. So she knows the struggles of women in medicine, and she provides complete freedom as per our schedule, and so that is the biggest advantage that I'm seeing in Bangalore Hospital. I can talk about Bangalore Hospital for sure.
What about the staff? Is it organized or is it?
No, the staff is extremely competent and organized.
But not as much as Singapore. There's no way.
And no. There we don't have medical transcriptionists.
Oh, okay, yeah.
So here,
there's little differences like that.
Yeah. So here I have a medical transcriptionist with me, and so that makes the scanning reporting time even faster. Yeah. The support, yes. So now I can say I got the point. Okay, sorry, you got it. Okay, so the support staff that we have in India is really competent, and we have support staff for everything. From once the patient comes to the hospital, from the the ward boy and the nursing staff. Like I have transcriptionists for my reporting system, which makes it so much faster. I can report in the same time much more scans, because there's somebody who's trained to do that. So the support staff is very trained, and we have support at every step on the way.
I also felt like when we're having such a fast machine, the reporting shouldn't slow down.
Yes.
So we really try to
Yes.
make the radiologist as comfortable with
Yes,
this.
yes.
And in America, a lot of the time the scanning is done by a technician. Like for all my pregnancy scans, it was done by a technician.
Yes, that is one point, very good point that you highlighted. So the ultrasound scanning is done by technicians in Singapore, in US. So in India, you have a doctor who's doing your scanning, who knows, who has studied
and
MBBS.
ultra classified, not ultra.
Yes, you have
qualified.
the ultra specialist in fetal medicine who are doing your scanning. And if we are trained 5.5 years of MBBS we have done, we know what we are looking at, and if we see something, what else to look for. So that knowledge,
is important.
Yes, not just the technique.
Now that we've covered all the deep technicalities of the machine, how can this actually help patients? What kind of patients would actually benefit from a CT or?
The list is very long. One of the important scenario is a trauma. So where the patient, you need to polyscan, there's a trauma, you need to see where is the injury, how bad is the injury. The patient cannot breath hold. I cannot ask the patient to breath hold. So the CT, the best part of a CT is it is very fast. It is non-invasive, meaning I don't have to put any puncture anything or do any kind of thing, and we can see everything beautifully: bones, soft tissue, viscera, lungs, everything we can see very clearly. It is precise. So because of that, the CT is the best choice in a case of trauma. I have a patient who has a road traffic accident, and within, if I say whole body scan, within 9 seconds, I know exactly which bone has fractured, where is the hematoma, every detail that a neurologist wants, a surgeon wants. I have it.
Vascular.
Yes, vascular. It is life saving. So trauma is a treaty is irreplaceable in trauma, I will say. Then cardiac, we are doing not just diagnostic, where it is now a screening tool in patient who are 40 plus, who have a family history of cardiac diseases. Their lipids and cholesterols are high. So the patient, instead of taking from the usual angiogram, the CT is non-invasive. I just have to put a contrast through, and I know which vessel is blocked, with how much is the blockage, and then the cardiologist will take a decision whether to go in or not. So it's a very good screening tool, for the cardiac patients. Then stroke, MRI is also great imaging, but CT, it is widely available. It is very, very fast. So in the stroke patients, like to see the bleeding, because that determines the treatment guidelines, what medication we can give and we cannot give. And for the early intervention of stroke, like is the patient ideal candidate for undergoing thrombectomy, all that we can find out with CT. Then in tumors, so where we are suspecting tumors for any reason, whether it is head, neck, chest, abdomen and pelvis, bones, tumor evaluation. So these are the broad categories that I'll say. It is very, very useful.
So anyone and everyone who's feels like something's up.
Yes, and orthopedic fractures.
Fractures, yeah.
It is amazing.
Yeah, so CT is like bones, lymph nodes,
everything. And so we can see all the soft tissues with the new latest. We can see all the soft tissues very well. And also another thing that I want, because we are using like high, the 4th generation scanners and the minimum slice thickness that we talked about, we can see lesions which are as small as 1 to 2 mm as well.
Yeah.
Just need to, So that smaller thing we can pick up, in the lungs all the time. 2 mm nodules we are picking up and then following up, and we don't know what they are going to turn into. So we are picking things so early, like 2 mm.
Yeah. So we do a lot of breast imaging and breast treatment together. So if somebody comes in for a lump or some breast pain, then I take them down to Dr. Divya and we do an ultrasound, and sometimes we go for a breast MRI, because in dense breasts we'd rather do an MRI, and it kind of takes similar amount of time, and this time nobody's touching you, so I prefer it for myself. And we do a lot of biopsies that are guided with ultrasound. So she'll be showing me the probe, and then I pick up the lesion from that. So we do a lot of breast imaging too. So as part and parcel of a normal screening, which I'll just plug in. After 40, you need a yearly mammogram or a sonomammogram by a very good radiologist, because sonomammo, there can be differences in the scanning person, right?
It is completely dependent on the operator. So it is a very, very operator dependent. That is one of the disadvantage of ultrasound, if I may say so. Because advantages are many. There is cheap, rapidly available. It's no radiation, but it is operator dependent. Yeah, and as you correctly pointed out, the MRI, which we can talk about it later. So, like breast implant cases, breast MRI is the best.
Is the best, yeah,
for that.
Yeah, exactly, and especially some older generation of implants have a certain tendency for some cancers. So breast MRI, keeping them on follow-up is very important. Also, before you get your breast done, you must have some type of breast imaging done. I always do MRI, because that becomes your baseline before your breast changes again. So that's very important.
That's a very good point.
Yeah. Just a side note. And How do you feel about prevention? Because in India now, there are a bunch of centers. Even in America, they've opened a lot of centers who do preventative MRI scans, where you go in and get your full body done and you get a report. And then in India, there are centers who are doing preventative CT scans. So we are doing both basically only based on the confidence of our machines, so that we know we're not risking patients for radiation. But as a radiologist, what's your opinion on that?
Yes, absolutely. So with my time at Bangalore Hospital, I have done many
Yeah.
whole body CTs and whole body MRIs, and I'm myself surprised, like, so many things that we pick up. There are so many variations that we pick up. Like, I'll highlight, there was a patient with kissing carotids that we call. The carotids were very close. They were normally go like this. In that patient, they were very close. So we made a note of it, like, God forbid, if there is a future need of an intervention where the airway needs to be put in,
Yeah.
we need to be the clinician. If they know that there's a carotid right behind it, they'll be careful.
Yeah.
So all those things. So anatomic variants. Then we have found the first case that I did had an adrenal lesion, and now the patient is on follow up for that adrenal lesion. So things like that,
And they come in just like that, because
Yep.
most of it, our business started really from friends of friends who heard that we have it, and news spread, and now they want to get their bodies imaged and checked out. So they're really just normal people who are coming in, because nowadays the kind of scare about
Yes.
sudden heart attacks, young heart attacks, then all these cancers, the incidence has increased. So people are really starting to think like, hey, it's better to just know ahead
Yes.
of time, because they're also figuring out that sometimes what they found today at a stage 2 could have been found like 6 months
Absolutely.
earlier at stage
And as
1.
I said, we can detect something as small as 2 mm.
2 mm, right.
And you can put it on the follow-up.
Yeah. So if you're going to get a preventative scan,
Yeah.
go to the best center with the best machine.
Yes.
Because if you're undergoing it, taking the time, spending the money, you want to make sure the machine is doing its job and the radiologist is able to extract as much information. And what do you think about preventative MRIs?
Yes. So
How does the patient make the choice?
uh, the CT and MR both will give us the complete body picture. The CT is very, very fast, and what we usually do is we also do cardiac scan along with it. So with the one dose of contrast, the patient gets to know about the cardiac health as well as the entire body health. MRI, the advantage is that there's no radiation, absolutely no radiation, but it takes a longer time duration. So that's the so as I said, all these technologies have different technology behind them and different reasons.
Yeah.
One cannot replace the other.
Right.
We have to make a judicious choice of what to go with. As you said, like if you got a CT, whole body CT done, and then you can follow it up with an MRI, like that.
Yeah.
So we have to let your doctor choose for you.
Yeah, that's actually the best decision. And we have actually gotten the MRI recently to 38 minutes for full body.
Yes.
Which is the shortest amount of
Yes.
time it's been going on in Bangalore.
Yes, and I remember
Yeah.
in one of the patients there was a liver lesion the patient was not aware of.
Yeah.
And now we did then all the tumor markers and we are like evaluating the patient.
The patient,
Yeah.
So the good thing about having this only in India machine is that a lot of the top talent people come and like, for example, people who make radiology programs, people who are working in radiology and AI, radiologists, for example, and they really, really want to make the machine work for their uses. So now we also do a lot of pediatric cases.
Yes, that's right.
So and all our radiologists and all our doctors prefer to use our machine, even if they live far away or whatever. So that way it's good to have the community kind of working to make it a success, because it's so important for the community, for the patients and everybody.
And as you highlighted, it can be used in a lot of pediatric patients. In fact, MRI is absolute. Fetal MRI is also being done.
Yes.
Because MRI is a safe technology.
Mm-hmm. And the CTs also get the kid imaged quickly. So the child is not struggling inside the machine. It's like very quick in and out. And sometimes in other centers, they may sedate the child so that they shouldn't get that artifact like you were talking about. So they don't want movement of the child. So they sedate the patient or the child. And so we avoid all that with having a quick, easy machine. Now that we have covered a lot about the CT machine, what about the MRI? In Bangalore hospitals, we have a 3 Tesla wide bore MRI. Could you just explain what that means?
So MRI is basically magnetic resonance imaging. We have a very strong magnet. So to put in perspective, Earth magnetism is it is 50 microtesla, and what we have is 3 Tesla, which is 60,000 times the magnetic force of the Earth. So it's a very strong, powerful magnet that we have. And routinely, 3 Tesla is not easily available, I must say. It's usually 1.5 Tesla. In fact, people are doing it on 0.5 Tesla as well. So the stronger the magnetic force is, the higher the soft tissue resolution is. Soft tissue resolution meaning in CT, as I said, we can detect something that as small as 2 mm, 1 to 2 mm. Here, we can actually tell what is the content. Is it water? Is it fat we are looking at? Is it calcium we are looking at? Is it blood? To imagine, without poking the patient, we can tell what that lesion or what that thing is made of. So we can tell the composition. That is how strong and amazing MRI is. And having a 3 Tesla MRI, you can pick up very minute details that, the stronger the Tesla is, the stronger the magnetic force is, the better the image quality is. So 3 Tesla nowadays, like in US and all, mostly it's 3 Tesla for musculoskeletal imaging, because the detail is just mind-blowing.
Right, yeah.
We can see through the nerves, the how the nerves are formed, how they're moving out.
Fascicles.
So, yes, everything. The resolution is just amazing. And it's a constant learning for us as the new technology comes in.
How is it like a new learning for you guys? Is it the settings, or is it more like you see?
We need to get our eyes used to what we were looking at 0.5 Tesla. Now at 1 Tesla, we are suddenly seeing much more.
Yeah.
So that's the learning curve. Now the new machine, stronger machine, we are seeing better details. So that's a learning curve.
How do you update yourself? Like, is it reading, or is it all like kind of practical experience?
Yes, it's basically the same scanning modality, but it's what we are seeing on the routine basis, and more than as the experience. That's why we call ourselves practice, medical practice. We learn with practice.
Very well said. I actually never thought of that. That is probably why you call it practice. Yeah. And what about for the MRI? Is there any specific things where it does better than a CT? Because as surgeons, like I make certain choices based on what we've studied, that it's better for soft tissue.
That's a very good point. So and many patients and many people have this misconception that MRI is better than CT. No, both are different. One is an X-ray machine, an advanced ionizing radiation machine, and another is using magnetic force to detect. Okay, so CT has better spatial resolution, like we can see the smaller things more clearly. In MRI, we can see the soft tissue resolution better. So it is very, very good for neuro cases, for spine cases, for musculoskeletal cases. And then we are now doing it prostate cancers, rectal cancers, fistula in ano, it's a small tract. We can actually tell you where all it is going, and it is very important for the surgery. Otherwise, if the surgeon doesn't know what all the branching and everything is, the surgery might not be successful.
To you. And she had been treated outside for a week with just antibiotics. They couldn't figure it out. But she has actually, after I spoke to her, she was saying that she has had like recurrent infections for like since COVID time.
Yes.
So then even though there was not much of a swelling there, I sent her for a fistulogram.
That's right.
And you had reported like literally a 1.5 to 2
mm
fistula that was a little bit in the intersphincteric plane. And in the surgery, we actually got that. when we injected the dye, we were able to identify that, remove it, and she's quite comfortable now, and she's moving around.
That's the beauty of
Yeah.
MRI. So if
Yeah.
we give you all the details, there's a chance, the surgery.
Yeah.
Yeah, it's a help.
Because as good as you are as a surgeon or your clinical judgment now in 2025, when you've got all this at your
Yes.
disposal.
Yes.
So I'm
You should
like,
use-
yeah, unless the patient has some financial constraint or
Yes.
whatever, I always tell them like, look, we've got this option. If you're okay, we can do it, and we get really good imaging, a really good resolution. And when
That's
I'm
right.
going in, I'm not going in on a educated guess.
Yes, that's
I'm
right.
going in
That's
100%,
right. That's
which is
right.
super, super important.
That's right.
Not as much for me because I'm sure what's going on there, very much for the patient and the family. Because
That's
when you give the report and you give it in such a great way that it tells, I'm able to explain to the patient. Actually, I guess we never speak about this, but we did on
Yes.
the way here. Actually, we were really talking about the patients. But then I showed the attender that day, like, see, look, like this is what's happening, and so this is what we're trying to remove, and then I draw a picture to support your drawing, so to support your report, and show them like this is what's happening.
That's right. So
And
as a
then,
patient, we
yeah,
can take an informed decision.
informed decision on whether they want to wait, they want to go ahead, or whatever. So that way, it's really, really good to collaborate between a
Yes.
radiologist and surgeon. So I was talking to Dr. Divya on the way here, and she was saying that she was doing like teleradiology and helping other institutions out when they send her scans. But one of the reasons she's come with us to Bangalore hospitals is because she loves being part of the hospital.
Yeah. There's a term for radiology, armchair radiology, that you're sitting in a dark room and just
Yeah.
reporting on your own.
Yeah.
No, in today's day and age, we should be a clinical radiologist.
Right.
We should interact with the patient. I shouldn't discuss with you. So that is always good for the patient outcome point of view. When you give your perspective, I give my perspective. So that is how we decide for what is the best outcome for the patient.
Yeah.
So then the learning. So when I say something and now you're telling me that it was there, so I'm happy and relieved. But if
Yeah.
not, then it's a learning for
Yeah,
me. So it's a never-ending learning
Yeah.
practice.
Yeah. And so you guys also, so as surgeons, we get a bit jealous because it's like, we send you the patient, you get to sit and chill in an AC room. In training, that was a big deal because like we don't
Yeah.
have AC outside.
Yeah,
So
yeah.
like you guys sit in an AC room, look at the
yeah,
report and just tell us.
Yeah.
But then I'm sure like I have patients, I go home and I think about it at night, and in the car you were mentioning that even when you write reports you think like, oh, was it this, was it that?
Yes, because ultimately the feedback that we get from the clinician is what the learning
Yes.
is.
Yes.
Yes.
Yeah.
So that discussion, that inpatient and the clinical, the discussion, that is what I really like about. And we have a very team closely, who work very closely together.
Yeah.
Like for every patient, I'll like catch any doctor and then ask what happened to that patient.
Yeah.
So that kind of relation we have in
Yeah.
the hospital, that is what I really like
Right.
about. Yeah.
So we just had a patient, 31-year-old, who had query breast cancer. She thought it was cancer, and we came in, did the scan, did the biopsy with the help of ultrasound guidance, and we had sent everything, and both of us were consistently talking about it because we were also like, oh my God, she's 31. Like, if this is the case, we've got to change the way we image
Yes,
people.
yes.
And luckily, it has come as mastitis, so probably recurrent infections during breastfeeding and all that caused it. But so when I had called up Dr. Divya and said, hey, actually, you know what, it's not cancer, she's like, oh, thank God. So that's
Yeah.
really nice from a surgeon's point of view to see that the radiologist is also just as invested in it. So that to me is like super, super special, and you don't actually see that quite often. Speaking about extra compassion and extra interest, it's probably because you're also a woman. Just kidding. Some men are also decent enough, especially, do you think that there's such a difference between male doctors and women doctors?
Women doctors generally, I think they're better at listening, and which leads to better patient outcome and care, I mean, yeah, guys are
Yeah.
doing fine too.
Yeah, they have been from ages. They have been
But
doing
then
just
women
fine.
are good at multitasking.
Yeah.
Like, look at our Dr. Larry. She's a mother of a toddler, a CEO, and a surgeon. How do you do it all?
I am, yeah, like when people ask that, I say, like, I'm really not. I basically separate my days into, like, mom days, boss days, surgeon days, and, like, somehow manage that way. But I do have a lot of help. You can follow me on my Insta to see all the ways I deal with my unreal responsibilities. But,
So yeah, we are good at multitasking.
yeah, yes.
Generally, yes.
So we're great at multitasking, and it's like when you put a stone under pressure, it becomes a diamond.
right.
I feel like that's kind of what it is, because when I see, it's not just us doctors, all the staff. I mean, a lot of people travel from
Yes.
so far, and they come and they do their work like a
Yes.
boss, and then they go home, and some of
Absolutely.
them wake up, like you wake up at 6, send your kids to school, and I mean, I'm really bad in that way. She's just in, like, earlier, so I don't actually get up and drop her, but I'm sure that's coming to me soon.
Eventually.
But so it's really that we have a lot of other things to focus on as well. But there are some reports recently that women doctors have better outcomes. So in US, some trials have been done. I mean, some studies have been done. I don't know how real that is, because I think, like, I'm married to a really phenomenal doctor.
That's true.
One of my best friends is a really phenomenal doctor. So I don't know if that variation really boils down to gender, but it's just like how a person's background colors the way that they are. That's what probably gives the differences in the hospital. So as you rightly said, because we have so many responsibilities, we learn to wear 2-3 hats at one time, and we're able to use all that and be, like, maybe more compassionate or more sensitive of their time, or especially women to women.
That's true.
There's a good connection there. So maybe those are the reasons. But did you feel it was harder training because you were a woman?
Yes. So I'm sure you must have experienced that too.
Yeah.
When you're walking with a male colleague or even your junior, and
Yeah.
then patients and the attenders, they will think that you're a nurse
Oh
and
my
not a
God.
doctor.
Yeah.
Yeah, it happens all the time, because
Yeah.
there are inherent biases in
Yeah,
our society. We have to,
Yeah, and you trained in India?
Yes,
Yeah.
yes.
So
I'm trained in Delhi.
literally, when I'm operating on his hand, and, like, it's only me and the nurse, and he's like, oh, when is the doctor coming? Doctor yavag bartare, madam?
Yeah.
Sister.
Yeah,
Yeah.
these are the biases that we deal on a day-to-day basis.
Or, like,
That's
when we
right.
go for rounds and they ask us when the food is coming or when this is coming. So honestly, that way I feel like guys just walk in the light.
Yeah, that's
like
true.
they don't
They've never
even
faced
know,
all of
yeah,
that.
they've never faced that kind of stuff where they're like when I was in training,
People undermining you.
yeah, constantly. And we are also taught during our training to man up.
Yeah.
Right? Is
Yeah.
to, like, we can't complain about it,
Yeah,
and we can't
exactly.
we can't even acknowledge it.
Yeah.
Yeah, so you really can't express even that, hey, this person said this to me or that person said that, because even in India and even in America, like, certain things are there where it's like, it's still new that the woman is now not just in medical school, but then studying to be a surgeon or a radiologist, and it really changes the game. And I feel like surgeons especially,
Yes.
I don't know if
Very
that's the
few.
truth, but
Yeah, very few.
like my one of my bosses in my training, she was one of the first MCH plastic surgery in Karnataka, and then I was pregnant at that time, and she took me aside and she told me, like, look, you don't have to explain. Like, I had an issue in my pregnancy. There was COVID, and I had actually some bleeding, and it was, a little bit of a threat to the baby. And I was like, I felt like when I was taking the time off, or like the doctor told me to take this bed rest time, I was guilty, first of all. And, like, I felt like I'm letting the other three down who were with me, my co-PGs, and then also like feeling like I joined and then this whole thing happened and I can't operate. Because of the C-arm for hand surgeries and all, I can't operate. I can't do much. I can just basically sit there and write discharge summaries or whatever. But and the main thing that this I'm just coming back to me is that she took me aside and I was telling everyone like, no sir, like I had this, I was in the OP and then I had this bleeding issue and I had to be rushed to the hospital, the other hospital where I was being seen, and they had to do this and this, and she overheard me and she took me aside and said like, look, you don't have to explain yourself. Like, being
That's true.
pregnant is a totally normal thing. How would they get their children unless women birth the babies? Like, it's not like we're doing it for ourselves. It's like it's for the world, for the community. And honestly, like, if we were given a choice, yeah, we'd want men to also give birth. It's not like we love the experience. I mean, some people do, but I didn't like really love it. But like, we like, it's not our fault and it's not something that we have to feel guilty about, and it's a normal thing. And if we're in school for God knows how many years, like literally I joined medicine in 2009, it's 2025, like it's such a long journey. You can't expect to not get married, not go to your siblings' weddings, or not go anywhere, not have a child, not have a family. Like, I feel like things do need to change in that.
That's right.
Yeah.
That's
Do
a
you have
very
any similar experiences?
Yeah, it's I have two kids.
Yeah.
It's been some time now, so
Yeah.
yeah, the experience is not so fresh.
Yeah.
But yes, it was very hard and challenging. Like I remember when I was having my kid and I was like working nonstop. I wouldn't get time for my lunch. Whereas as doctor, we only suggest that you have time leave meals, and after meal you should count your number of baby kicks. But I don't have time for that.
Yeah, exactly.
So those are those are
Yeah.
challenges. So
Yeah.
it's not as you were saying that everybody needs to know that it's not the finished picture. There's a lot.
There's a lot to
that
yeah,
goes
yeah,
behind
exactly.
it.
So what I was saying is like, some people, especially medical students or people in training, see us when we're practicing and thinking like, yeah, it's all good, but it's really, really, really grueling to get to where we are right now. And it's a lot of character building, and it's a lot
That's
of
true.
sorting out who you are. What does it mean to be a woman? Should we stand out and be a woman? So even as a CEO, I get a lot of people being like, so how is it being a woman CEO? I'm like, well, it's just as hard, but then
Yeah.
I also don't know how it is being a male CEO.
That's
But
a
for
good
me,
point.
it's
Yeah.
really, really
Very
hard.
That's right.
Yeah, because first of all, I mean, this is doctors on doctors, but as a woman CEO, like, there's
Yes.
definitely
Yes.
less respect. Yeah, like
No.
there's definitely, like, you were saying that because I'm a woman, I'm able to understand more, and that's all there. But it's still like, even from the women or even from the male staffs, male doctors,
That's true.
there's definitely, I wouldn't say they're rude, but then they don't they would treat, like, for example, Abhishek differently if he
Yes.
sat in the chair, but then it's me
Yes.
sitting in the chair. And
Yes.
I can always see when people walk in, like doctors, they may sometimes, Abhishek joins me for the doctor meetings and they'll be just talking to him,
Yes.
right?
Yes,
Like,
yes,
they'll
yes.
think like I'm just sitting here and
Yes.
he's the one making the decision. So that, it happens.
Yes.
It's not like we're not talking about some 200 years ago.
And these things need to change. It's
Yeah.
the mindset. It's the mindset.
It's the
Yeah.
mindset of us, and it's the mindset of others. But I also struggle asserting myself, right? Like, I struggle just saying like, hi, I am the one here. So I'll just let it happen sometimes. But now I'm learning to like say
Yes.
like, hey, I'm the person you've got to deal with, unfortunately for you, but I'm the one here.
It's really nice that you brought it up because we
Yeah.
don't talk about it often.
Yeah.
And it is we all of us face this
Yeah.
and but we don't talk about it
Yeah.
often. So
Yeah.
that's a
Yeah.
very good point that you've and so people should know that this
Yeah.
happens. It's not rosy
Yeah.
always. It's a tough journey.
Yeah.
But you can do it.
It's a difficult, and once you become doctors, like, for all the people out there who are in their training residencies, or MBBS and all, like once you become a consultant, the road to being a consultant is really, really laid with thorns, because it's not, the life really isn't made for us. And I feel like a lot of the women consultants who came before us, they had it worse. So when they had it worse, half of them are like hardened, they're like,
Yeah, that's true.
you also go through it, and you'll, because of all that
Yes.
trials and tribulations, you're going to
Yes.
also be strong. Which, okay, that makes sense. And then there's another side of the seniors who are like very like, hey, take some time, do this, do that. But then for us to actually take the time, I mean, how do you feel when you have to leave work? I know your kid got sick that day, right? And you had
Yes,
to go
yes,
in
yes,
the middle
yes.
of the day. How did
Yes.
that make you feel?
Yeah, I felt guilty of
Yeah.
not being able to, for not being present at the work, because I had to leave. My son got a fracture recently while playing, and he needs me there as a mother, as a doctor.
Yeah.
But at the same time, I have my patients waiting for me. So when my son was young, and we have to give appointments, patient must have taken day off at their work, and suddenly my child got very sick. There was a time, and the obviously the play school will not take a sick child.
Yeah.
And how do I go about it now?
Yeah.
Because somebody has taken their day off
Yeah.
to meet me.
Yeah.
I cannot back out now.
Yeah. Yeah.
So I had to take
Yeah.
my sick child to the work.
Yeah.
Yeah. So these
Just
are the,
asking, and at work, were they cool with it?
yeah,
Yeah.
they had to. I mean, there was no other option.
no
I
other
couldn't
option,
leave.
yeah.
But my husband, he travels a lot. Every 3 months, he's away. He can be there outside
Yeah.
2 weeks, and a household will run smooth,
Yeah,
smoothly.
exactly.
So, yeah.
But it's vice versa. It's not the same.
It's
yeah,
not.
yeah, not at all.
Let's accept it.
Yeah, and like I had a Women's Day celebration I think it was last month or something, and they were like, so how does it feel? Being a woman in healthcare? And I said, like, well, I think it's the same. And she said that, why do you think it's the same? I feel like it's more difficult. I said, why? And she says, because, we've got a house to run, we've got all this, we've got to handle the kids and everything. And I said, well, we need to start making it 50-50. Like, I am always on top of Abhishek
Yes.
to say, like, look, you've got to do it too.
Yes.
And so now, and even somebody as worldly or as modern as our colleagues are in medicine, still they don't, because you've got to walk a mile in her shoes.
Yeah.
I think that's really important. Unless they walk a mile in her shoes, they're never going to really get it. So when they do make reports about women doctors being better, whatever, sometimes I'm like, maybe there is a secret sauce. Maybe it's our
the
tears
compassion.
and guilt.
It's
like,
the compassion for the work that we are
Yeah,
doing,
yeah.
despite all that. We
Yeah.
overcome it all
Yeah.
for the compassion,
Yeah, yeah.
because we are it's just about it's so much about compassion. Yeah.
And also a little bit of opportunity. Like, I feel like, okay, I've been given this opportunity, even though I have, like,
Yes.
sometimes my male counterparts, it's a right. It's like, as you could do engineering,
Yes,
you can do this, you
yes,
can do
yes,
that.
yes.
For us, it's like, I've been given this opportunity to sit at the top of this team as a surgeon in the OR or as a radiologist in the department. And, like, now I'm not going to let it go now. I'm going to make the best and have the best
Yes.
outcome. So we are always in that, like, survival mode, I
That's
feel.
true. That's true. And
Yeah.
also, both of us have daughters, so they
Yeah.
and we are good. I feel that we are setting up good examples
Yeah.
for them. That
Yeah.
okay, they will see us struggle every day.
Yeah.
But at the end of the day, that my mother can do it all. So
Yeah,
I'm
yeah,
sure
yeah.
that will help them. When they grow up.
Yeah. Make and that helps them to make all the choices.
Yes.
Like, ultimately, what I want for my daughter is to be able to choose whatever she wants to
Yes,
choose,
yes.
and not have to be hindered by this guy, that guy, this issue, that issue.
Yes,
Like,
yes.
girls need to be free. I think,
Yes.
like, as much as I love guys and I feel everybody's equal, but
Yes.
girls, the young girls nowadays, they have got to be free. They've got to have all the opportunities that other people have, and I think we're still lacking in that.
Yes,
Yeah.
so hopefully that with people who are watching this, they more girls take up medicine and
yeah.
be CEOs and
Yeah.
so that we can
Yeah.
make it easier for the
Yeah,
next
yeah.
generation to come.
Yeah, and for you guys, when I was in training, when the patient calls me sister, I would correct them.
Yes.
Even if my boss is next to me, I would correct them, because it's important. It's important. There's no reason why you should just be assumed to be a nurse. Not because being a nurse is bad or less than. It's just that even the women nurses say, "Ye madam nori nimana itara helta idru," because the women nurses respect us, and they feel like, why are they making this assumption? Because ultimately we're one kind.
Team.
All women are one team. So they also get frustrated about it. So stand up, even in these little micro ways. Just stand up and do it, because what's gonna happen? Nothing. You're just asserting for yourself. That's it. We need to stop being so fearful. I had a patient literally 3 days ago. The patient came from Bengal, and she's got this mark on the face, and the parents really, really badly, because we see a lot of people who, they want to get married. They want the girl to get married, and they were like adamant that they want it to be removed. And she's like, I don't care. I don't want to. I'm scared of the surgery. I'm scared of the surgery. And, so the dad was like saying, no, be quiet. You need it. You need to get married. And so after he left, I came back without telling them that I'm coming for rounds. And I sat there with her on Google Translate, because I don't speak Bengali. And I told her, look, I'm not going to do it unless you tell me to do it. That's 100%. And then I told the father and mother that too. I am not touching her face unless she specifically tells me that she wants it and I believe her. Because, the pressure for girls, if she doesn't care about it, why do you? And he's not even asking her, why she doesn't want it.
That's right.
So after time, she said, no, I'm just scared. And I said, but do you want it gone? Yes.
So this is the perfect example of what we were discussing. Women are more compassionate.
Yeah.
Actually
taking the time to go back. And
so you just proved it.
Yeah. Because it's
because we understand. We have been in
We've
that
been
shoes.
there with the parents telling, get married, and
and the society constantly putting all sorts of
things,
parameters and pressures.
Yeah. All right, so now for some fun. We do a little rapid fire round. So I'm going to ask you a few questions. Give me the first thing that comes to your head. So number 1, what's the strangest thing you've ever found on a scan?
Yeah, so the strangest case has to be one of my cases. I had to literally open up books and read about it because I had not heard about it. There was a male, 40 plus. He had 2 daughters, both married, living his life happily, came for a scan for a hernia surgery before the hernia surgery. And when we did the scan, as I told you, without poking the patient, we can see everything inside. And we found a uterus inside. Okay, so that was an MRI scan, and then we confirmed it, and even it was confirmed on surgery as well. So it was a very rare type of pseudohermaphrodite, which was the patient was genotypically and phenotypically male, but the female organs were present, which did not when we grow up, then they shrivel, so that didn't happen for that patient. So had female organs as well inside, and the patient was really had a shock of his life. So and for us also, it was the first time. It's a very, very rare case that we happened to see.
Crazy. You would have had to check again and again and again.
Yes. We thought we are just reading it wrong. Or what?
Or reading somebody else's.
Yes, then did an ultrasound, and then there was it was what it was.
Wow.
And we had to give it
Nice.
So that's the tough part.
That actually is the weirdest thing I've probably ever seen on a scan. All right, so the next one is, if your life was a movie title, what would you say?
Sherlock Holmes.
Yeah.
That was my favorite character as a kid, and I'm living that life. So it's a medical crime scene, and we are the detectives.
Yeah, you must actually feel like you're...
Yeah, I actually get inspired by Sherlock Holmes.
Really?
Because there are clues which give us the diagnosis. We have to give the correct diagnosis, right? There are clues in our body which guide us to the diagnosis. So it's like that. Yeah.
So that's why you call people up call the doctors up. Like you've called me being like, hey, but did you see this and this? Did you ask her this and
Yes,
this?
that's why I keep because there are clues.
Yeah.
So body, it's everything is inside. We have to be
Yes.
able to read it, and so Sherlock Holmes. It's inspiring also.
Yeah. What's one of the cases where you feel like you had an aha moment, like you put a bunch of things together and was like, oh my gosh, it's this.
So there was an ultrasound case, and as per guidelines, we just have to tell if this baby's stomach is seen or not seen. And in that case, the baby's stomach was seen. So ideally, I should have just discharged the patient. But then it's the practice, right? Because we have been practicing for long. There's a sixth sense that comes to us, and I was not happy. I asked the patient to wait. Again, the baby's stomach was small. Then I called the patient again because I just want to be 100% sure. Next day also, the baby's stomach was small. It was seen, but it was small. So I raised it. I raised as a possibility that there may be a tracheoesophageal fistula, which is causing basically a communication between the airway and the gut GIT tract that is causing the stomach is perpetually small.
Right.
And then it was proven after birth, and then the patient went early intervention because of that, because I had already raised it.
Wow.
Yeah.
So in the initial scans, it was not seen.
As per guidelines, we have to just say the stomach bubble seen, present, or not present. But it was small, and I want to be sure that before giving any clearance.
Very nice.
Yes, and that comes with practice, right? Because AI is coming up, right? So in the AI will give you a methodical approach, whereas over years that we develop a sixth sense.
Yeah.
So we can feel it that something is not right, and then we work on it, and then
Do you think that AI can replace radiologists? Because that's
a lot of buzz about that's a buzzword about it. So yes, I take AI as a helpful tool, as a something that will be assist me as maybe just to make sure that I have not missed anything.
Yeah.
Then it can flag up if there are a lot of cases that there's an urgent case. You better look up.
Yeah.
So I take AI as that tool. So I always say like autopilot has been there for years, but we still need two pilots because whenever human lives are at risk, you can't just leave it on AI. So yes, it
very well said.
Yeah, it'll just help us.
Yeah.
I take it as a helping tool. Yeah.
What's one thing you wish people knew about radiology?
Yeah, so there are two biases. One is a women in in medicine, and the second is being a radiologist. People don't think that you are a doctor because they don't see you. So I will say radiologists are actually doctors.
Yeah.
So the right diagnosis.
Radiologists are doctors.
The doctors are the one who come to us.
I don't disagree with that. Yeah. Yeah.
Because getting the right diagnosis is like setting on the right approach. And the another point, I draw a lot of parallels from life. It's like in a police force, you have a police officer and a detective. So I'm the detective and you are certain is the police officer.
Yeah, actually very true. Because without a radiologist, like getting to 100% diagnosis with that much clarity is difficult.
Yeah, so we have to, so it's like we are a team.
Yeah. So actually when Dr. Divya came to us, like she basically had a mutual contact who brought her to Bangalore hospitals, and I had met her, and she was thinking just to come like for a few hours or whatever, not really full time be here, but if we needed help we could use her as an advisor or whatever. But then I just felt like I had that gut feeling where I was like, no, this one is like a very talented person. And I was in need of a radiologist. But she had then gone to Italy. You had came and then you went to Italy for 2 months or so, 1 month?
Yeah, I mean,
a long trip. And I waited. Like I said, go do your thing, wait, but come back here. And then after she came back, and I felt like that was such a good decision on my part, because everybody compliments you. Like they love the reporting, and I hate when she sleeps because then I have to go for another radiologist. So
thank you very
that way
much for
we're
your
very, very
words.
happy, and I can really see your thought process permeating into your work, because it definitely is like that. So thank you so much, Dr. Divya, for being our first female doctor on Doctors on Doctors. It has been an absolute blast and such an honor. Thank you so much for being on the
Thank you
show.
so much for having me, Dr. Larry. I really had a fun time.
Great.
Thank you.
I hope that y'all learned a lot from this. This is actually a very, very special episode, and we hope to bring you really good content going forward. We'll see you at Bangalore hospitals, where the doctors have not just their professional lives, but personal lives that help them be the best doctors they can be. Like, subscribe, and share if you like what you see.